Welcome, everyone. My name is Dr. Ben Buchanan. I'm a clinical psychologist and CEO of NovoPsych, and I'm absolutely thrilled to be hosting tonight's webinar. We love running these sessions because they give us a chance to connect with the people who use NovoPsych, psychologists, psychiatrists, GPs, and other mental health professionals around the world who are passionate about improving care and who know that high quality assessment is an important part of that. At NovoPsych, we provide a range of psychological measures, including those related to ADHD. And I know many of you have been using these tools in your clinical work. And tonight is an opportunity to dive a little bit deeper into understanding ADHD and hear from someone who is truly exceptional in the space. So without further ado, it is my pleasure to introduce Jennifer Kemp, who is a clinical psychologist based in Adelaide, Australia. Her neurodiversity affirming approach is grounded in her own lived experience of being late diagnosed as autistic and an ADHDer, and experiences of neurodivergent clients, and also the latest research. Jennifer has published a number of books on ADHD, including the Neurodivergent Skills Workbook for Autism and ADHD. And Jennifer runs workshops and is a very sought after speaker. So we are very lucky to be joined with Jennifer tonight. Welcome, Jennifer.
Oh, hi Ben. It's great to see everyone. You're not wrong when you said the chat goes a bit nuts, doesn't it? It's just
Yeah,
gorgeous
I'm getting
seeing
this
hello,
pop-up.
hello. It's amazing.
Yeah. And so, Jennifer, when did you figure out you had ADHD?
In about 2022, so I was about 48 years old, and it was about a year after I'd realized that I was autistic and got assessed for that. And for a while there, I thought I was one of the rare autistic people that's not an ADHD because I've never handed anything in really late, although you did get the slides 5 minutes before this presentation. Like I would generally, like always finish all my assignments on time and so on and so on. And then I suddenly realized that there's quite a lot of hyperactivity. I'm very fidgety and restless and always have 15 million projects on the go. And it's all sort of started, I think once you're diagnosed with ADHD, or in some ways, some of your coping strategies fall apart. So I'm actually quite hard to get hold of now. But you persisted and I appreciate it.
Well, we're really pleased to have you here tonight, and the response to this webinar has been
Mm.
incredible. So, for the audience, Jennifer will be giving about an hour's worth presentation, and then she'll be passing to me, and I'll be demonstrating some of the psychometric tools on NovoPsych. And then at the end, we'll have a bit of a Q&A session as well. So it's a 90-minute presentation, and yeah, I look forward to demoing some of the tools we've got at the end. So, Jennifer, I think I'll pass it across to you.
Awesome. Let's get into it. Okay, hopefully you can all see that. All right, so we're going to
Yep,
talk today. You can? Cool.
yep, that's perfect.
Identifying and supporting ADHD. Just going to focus in on that topic. God, there's a lot I could say about this topic, so I've really had to hone it, and I'm very focused on trying to finish in an hour. So a little bit about me. I think you've covered pretty much all of this already, Ben. I'm the author of two book babies. Probably the most important thing on this slide, apart from being late diagnosed autistic and an ADHD, is the little puppy there. I think you might have heard him barking before. His name's Rocky. He's now 18 months old and he's not, most of that brown hair has grown out, sadly, and he is cute as a button, but he does tend to fire up if the doorbell rings, which is what happened earlier. So the Neurodivergent Skills Workbook was my most recent book with Monique Mitchelson. I think a few of you who are watching are probably familiar with that one. And I'm going to give you a highlights version of some of that and a few new slides if you've seen some work of mine before. I will be applying neurodiversity affirming principles in the presentation today, as I do in everything. So I'll be using identity first language In autism, that's pretty easy. We talk about an autistic person rather than a person with autism. In ADHD, we've got a very sort of pathologizing term that includes deficit and disorder in it. And a sort of workaround many of us using at the moment to use sort of identity first language with ADHD is to talk about ADHDers. So it's not ideal, and I'm hoping one day we get a better option. As much as possible, I'll be avoiding pathologizing, medicalized, and ableist language. So, in a couple of slides, I do refer to disorders as they're sort of defined in the DSM, but we won't be talking about ADHD as a disorder. We'll be talking about it as a neurotype or a neurobiological difference in a group of people, and always recognizing neurodivergent people as the experts in their lives. Okay. So ADHD consists of genetic differences in information processing. These are neurobiological differences. The one that is the most obvious, the most sort of dominant that you'll see quite often is this intense orientation towards interests. So for ADHDers, something is either really interesting or not at all interesting. And this can make it really hard to do boring tasks like admin, or if you're a psychologist, writing your notes, writing up reports. These things can become really difficult when you're an ADHDer. It's almost painful to make yourself do those things. You have to sort of brute force your way into doing them, and will tend to procrastinate on them a lot. So ADHDers tend to have short bursts of intense fascination and curiosity about certain topics. So you'll often find that ADHDers have a garage that has a lot of hobbies or crafts that they've bought everything for, but by the time everything's arrived, they've kind of lost interest. Half-finished projects around the house. They've discovered everything about how to renovate something, dismantled it, but never got around to putting it back together again. That's a very ADHD kind of pattern. And ADHDers, despite the name, have the ability to focus as long as something is novel, interesting, challenging, or an emergency. So ADHDs are very focused on novelty and challenge, and it can trigger a kind of hyper focus, a deep state of focus where everything else kind of fades away, quite frankly. And time becomes a sort of very elastic kind of thing. You can lose a lot of time. So you'll find ADHDers who are enjoying the task that they're on, who are finding it interesting and challenging, and might just get lost in that for a really extensive period of time, and can produce a really large amount of work in that sort of zone. Now, we don't know why ADHDers have this, what we'd call an interest-based nervous system. There are theories. There's the dopamine theory, which basically is that ADHDers have the same amount of dopamine as anyone else, but they tend to burn it up more quickly, and so are constantly running out or running a deficit in that. And so need and look for new sources of dopamine in sort of pleasurable activities. That's really a disputed kind of theory. It's not really been clearly proven. It does, though, describe that experience of when you find something that is intensely interesting, it does trigger a beautiful dopamine sort of feeling of joy and pleasure, and that you kind of mine that seam of pleasure. We call it dopamine mining. And then at some point the seam runs out, and all of a sudden that activity is just no longer interesting, and you cannot make yourself interested in it. It's gone, it's done. We don't know why we work like this. This particular study was really interesting. Used computer program and had ADHDers and non-ADHDers, and they found that ADHDers were more likely to seek novelty. So all participants were given a task to forage for different think food off certain plants. If they stayed too long in one location, they would over-farm it and then run out of food. But moving to a new location involved taking a risk that they may have to travel a long way and that there may be delays in getting the food. And ADHDers were more likely to seek novelty, to branch out, to find new sources of food. So the theory is that these novelty-seeking behaviors would have an evolutionary advantage for our ancestors, and that you need people in your community that are willing to take the risk, that are willing to try something new, just as you need people who are really content to stay where they are and keep working the food sources that you already have. So it's a fascinating study. All of the references you see through this presentation are listed in the references at the end of the document, and Ben is going to send out the slides so you'll have all of those references. A lot of people ask me for this one in particular, so you'll find the full reference and I think the link to the article in the references. So in addition to this orientation towards interests, ADHD is essentially defined in the diagnostic criteria by executive functioning difficulties. Now, executive functioning is around 99% genetic. This is my list of executive functions. This is most of them. So the ability to shift between things and initiate tasks, planning, organizing, prioritizing, decision-making, the ability to focus your attention, working memory, so the ability to hold information in your head and be able to use that information. That's the type of memory that you use when that you've not used when you go to the next room and you say, now, why was I in here again? That one, that's working memory. Tracking and managing time. So ADHDers often talk about this as time blindness, but we're not really using blindness, co-opting that term, and I think quite rightly blind people get a bit sick of people co-opting that for something that is not at all the same experience. So I tend to talk about tracking and managing time being a lot harder for ADHDers. Self-monitoring and self-management, so the ability to monitor your own behavior, the impact that it has on other people and how other people respond. And impulse control, inhibition, the ability to control those sort of urges and impulses. And the final one is emotion regulation. So our emotional regulation skills are an executive function, which explains why when we're in periods of our life where we have a lot on, so when we're moving house or starting a new job, starting school, those are the times when we're feeling completely overwhelmed, that our executive functioning is overwhelmed and it's kind of one down, all down. That's when we're more likely to lose our temper. Whenever you're moving house, someone always loses it, right? Because these are the kinds of situations where our executive functioning gets swamped. So it is a defining feature of ADHD is to have difficulties with emotion regulation, and you can see that in things like rejection sensitive dysphoria. That's a factor in that, the difficulty recovering from painful experiences like that. And finally, the use of repetitive behaviors for self-regulation. So ADHD is, it's often called hyperactivity. In autism speak, it's called stimming, and these repetitive behaviors serve important functions for soothing and calming or upregulating if you're feeling restless and bored. These behaviors help you stay in an optimal zone of sort of comfort or regulation. So we can define ADHD really by these four things. And this is what we'll be seeing in our clients. I'll give you lots of specific examples of what that can look like in a minute. A few other ADHD fundamentals. So ADHD is largely genetic, highly heritable. So you'll usually see it running down through families, although it may not have been in sort of older generations, it may not have been identified as ADHD, If you're an ADHD, you can probably think of a parent, maybe an auntie or uncle, sort of going up through the chain who is a bit of a scatterbrain or forgetful or has a million projects on the go and maybe highly anxious, may have been diagnosed with something else related to that. And that's the ADHD coming down through the family. That can mean that ADHDers can live in families that are more chaotic, more unstructured, where there's less routine, and so there's a sort of element of chaos in that family, which isn't always really helpful for kids when they're growing up. And so you will also see, and I'll talk about in a minute, other challenges that ADHDers often have in childhood. ADHD has shared genetic origins with autism and Tourette's. So in Tourette's, that's where you can see those repetitive behaviors, the premonitory urges, they're called in tics, that there's a powerful urge to do it and you can't really stop doing it. You'll often see ADHDers tapping their leg and they're often unaware that they're doing it. If you ask them to stop, which you probably wouldn't, but if you ask them to stop, and they got distracted, their leg will probably start tapping again. It's an urge, and their body is doing this repetitive behavior, and they don't have complete control over it. And there's a huge overlap between ADHD and autism, and you'll see all of those features, the intraspaced nervous system, executive functioning difficulties, emotional regulation difficulties, and repetitive behaviors in autism as well, although they do have some different features. It is, by the way, quite an arbitrary line that has been drawn between ADHD and autism, because about 85% at least of autistic people would also meet the criteria for ADHD, and at least half of all ADHDers would also be autistic. So there's a line that's been drawn that separates out the executive functioning, and it's arbitrary, really. They've drawn the line there. They really form with Tourette's a spectrum of differences, and people will have different features, different profiles within that. The prevalence in the population of ADHD is estimated to be approximately 5%, but you will find studies that range between 4 and even 12% occasionally. And often it's described as being 5% in children and a lesser percentage in adults. This can be really quite misleading, because if ADHD is largely genetic, it doesn't actually go away, does it? It can't really go away between childhood, adolescence, and adulthood. But what you will see is ADHD will look very different in adulthood, and it can be hidden too quite often. So these difficulties can be hidden by compensatory strategies that can support executive functioning. So extensive exercise. I have members of my family who need to exercise for over an hour every day, ideally probably closer to 2, and that seems to stabilize their ADHD. You'll often find long distance runners, long distance cyclists, I think, are possibly people who really need that really long amount of exercise every morning. And if they don't get it, they feel antsy and agitated. It sort of almost like it uses up the need for movement at the beginning of the day, and they feel calmer for the rest. You'll also see compensatory strategies such as I've used, with having absolutely everything in my diary as a way of managing my memory, basically. So everything goes in there, even pick up children from school will be in my diary, so that I know that I have to be there and do that. That's the extent. I cannot rely that I will know that I need to do it if it's not in my diary. And that's a compensatory strategy that's really common. You'll also see people for whom in adulthood they have external supports that are compensating for their difficulties. So they might do really well at their work, but have a partner that basically manages the entire rest of their lives. That's quite common. and is the person who manages the household socially, what needs to be bought at the shops, everything, and they do the tasks they need to. They don't carry that mental load. Sometimes that's the way that ADHDers can end up in these relationships. Or in their work, they have personal assistants or a whole team of people who basically compensate for the difficulties or challenges that they have. I can think of the sort of advertising executive who's a brilliant creative and has a whole team of people who organise his appointments or her appointments, structure their time, deliver on the projects, and they're just responsible for the ideas. That would be a situation where an ADHD could thrive because they have all of these extra supports compensating for their difficulties. Also, in adulthood, you might find unhelpful coping strategies that have then overshadowed ADHD. So, addictions, substance use, you will find quite a few ADHDers smoke weed, drink alcohol, do things to slow themselves down from that kind of hyperactive, perhaps, state that they would often feel in, slow down their thinking. And sometimes those blow out into addictions with substances and gambling, all sorts of things that then become problems in themselves and then overshadow ADHD. And of course, high intelligence can also mask or compensate for ADHD in children and adults. So people who are able to get things done at the last minute and still do them really well, who can find the quickest route to doing a task using intelligence can often really compensate for the difficulties. It will really hide ADHD as well. Is it overdiagnosed? I hear that a lot. It's not. Here in Australia and elsewhere around the world, the diagnostic rate is lower than the population prevalence. It's lower than 5%. And the huge surge of increase of diagnoses reflects the improved recognition of ADHD, particularly in girls, those assigned female at birth, and adult women, and particularly better recognition of the sort of inattentive and masked presentations. So people are more sensitive to finding ADHD when people have a lot of compensatory strategies that are, like I did, like holding everything together, kind of with sticky tape and chewing gum. But anyway, holding it together. There's improved, but we're not quite we're not quite there yet. Recognition of the relationship between estrogen and executive functioning. So for people who ovulate, for people who are assigned female at birth, or women, you will find that when estrogen fluctuates in the body, executive functioning changes as well. Whenever there's a drop in estrogen, there's often a loss of executive functioning capacity. So that happens every monthly menstrual cycle. It happens in puberty, in pregnancy, post-birth, in perimenopause, and in menopause. We have these fluctuating levels of estrogen, and it is often the case now that women who are in perimenopause, so over 40 years old, are finding that it's harder to cope with demands from every direction: children, parents, work, family, and feeling increasingly overwhelmed. And the loss of estrogen, or loss of reliable estrogen during that perimenopausal phase, can definitely contribute to that. And we're identifying members of this lost generation of adults who ADHD wasn't a thing when they went through school. And it's something that now they realize that they've been essentially playing life in hard mode. So ADHD has many friends, and it rarely comes to a party alone. It tends to bring a bunch of friends with it. About 50% of ADHDers would have at least one anxiety disorder, and possibly more than one. I've already talked about autism. There are very high rates of body-focused repetitive behaviors in ADHDers. I've got a few statistics I've pulled up here from some studies. So this study found that up to 32% of people with trichotillomania and or excoriation, skin picking, had ADHD. And interestingly, it's not necessarily being more sensitive, but it's more of a sensory seeking behavior, those kinds of things often. Around 30% of people in this study that had chronic fatigue or chronic fatigue ME had been diagnosed with ADHD in their childhood. 45% in this study of people who have fetal alcohol spectrum disorder of some kind also were ADHDers. Very high overlap with OCD. So if you see people with OCD or eating disorders that have obsessive qualities, then you'll always find ADHD is there. In one study, 25% of youth who had OCD were also ADHDers. And there's also very high rates of things like dyslexia, dyspraxia. At least 32% of ADHDers also have some kind of specific learning difficulty like those. And tics and Tourette's, very, very common. Now we understand that it's because of these shared genetic origins. So about 61% of children and nearly 40% of adults with Tourette's also have ADHD. So it's almost like the glue that sort of joins a lot of things together. And ADHD, the way it's defined, with difficulties with inhibition and impulse control and executive functioning, you can absolutely see how that could contribute to all sorts of mental health problems, certainly anxiety, definitely depression, burnout, all sorts of experiences that ADHDers can have. Now, I mentioned already playing life in hard mode, and this slide I've adapted from a paper and added a few things, changed the language to be a little bit more affirming. When we talk about ADHD as playing life in hard mode, we're talking about a whole bunch of different barriers that have quite big impacts into adulthood. So ADHDers are more likely to have developmental delays, speech, motor, communication difficulties, and these specific learning difficulties and executive functioning difficulties that can stretch from childhood through to their adult life, their entire adult life. With this can come difficulties with school, disengagement, being expelled, dropping out, and you'll then see difficulties with employment or underemployment, financial problems, and lower socioeconomic status. And all of the things listed here are significantly more likely in ADHDers than non-ADHDers. You'll also see more legal problems, criminality, incarceration, and death by homicide. And accidents, injuries, and as we go into adolescence, traffic accidents, violations, unplanned pregnancies, and accidental deaths. It's a bit gloomy. This is what we mean when we're talking about playing life in hard mode, because ADHDers are pushing up against this all the time. They struggle to finish school often, struggle to really stay engaged, and it has this knock-on effect through their life. The impulsive behavior then can have all sorts of unintended consequences in terms of accidents. And ADHDs do have higher death rates as well. I'll finish with that. Very cheerful, I know. I talked about the family chaos of coming from a family where there of ADHDs. You'll see higher rates of family breakdowns, domestic violence, interpersonal trauma, experiences of bullying, rejection, and relationship breakdowns from sort of our family of origin through to our own families. And along with the executive functioning difficulties with emotional regulation, anxiety, mental health, and higher rates of self-harm. ADHDers have lower self-compassion. They're harder on themselves than other people, very hard on themselves, in fact, very self-critical, have lower quality of life, lower self-esteem, and lower motivation because you have more experiences of trying things and getting stuck and having trouble finishing tasks, and it does affect motivation. ADHDers also have higher rates of physical health problems. So you'll see emerging in childhood and adolescence eating disordered behavior. That could be binge eating, could be bulimic behavior. There is a relationship between eating disorders such as anorexia and ADHD, higher rates of obesity, lifestyle and metabolic diseases, along with smoking, addictions and substance use, and higher rates of hypermobility, dysautonomia, chronic pain, and chronic fatigue. And you put all of this together, it's not really surprising then that ADHDers have higher rates of suicidal ideation, suicide attempts, and death by suicide. And all of this put together, particularly the accidental deaths and the deaths by suicide, result in much higher mortality rates and 8 to 12 years shorter lifespan. And that was a study that was a population, it was a large sort of population-based study. So this is what we mean when we're saying playing life in hard mode. And if you look across all of the things on here, you can probably see a bunch of your clients. They may have come to you for all sorts of reasons, for help with quitting smoking, for help losing weight or post-bariatric surgery. I have seen a lot of people around bariatric surgery and difficulties with eating of all kinds. Many of us work with trauma. You'll see that your clients with trauma may have these chaotic lives. And there can be this question of, is it trauma or is it ADHD? More often it's both in that instance. If this person is showing these broader executive functioning difficulties and they have trauma symptoms, it's highly likely that they have ADHD and trauma. There are higher rates of PTSD amongst ADHDers. Now, the DSM-5, I don't normally in my presentations refer to the DSM, but I felt that it was appropriate today. So apologies to all of you who were not expecting this if you've seen me present before. Can start with it. Let's put it that way. So the DSM-5 defines 3 presentations of ADHD as predominantly inattentive, predominantly hyperactive, impulsive, and combined. In my experience, I also look at it at another level. I might say predominantly autistic or predominantly ADHD, because sometimes either of those things can be sort of more obvious and dominate the other. And I always thought, okay, maybe I'm definitely inattentive. I really struggle in group conversations. I really struggle if something is boring, and actually realized that I'm a lot more hyperactive. And I think other people realized that before I was. So sometimes I think combined is honestly mostly what you're going to see. These presentations are no longer considered to be subtypes because they can't be clearly delineated and they change over time. So inattention is something that I've always dealt with my entire life, and hyperactivity was there too, and I didn't realize it. So I would say now that hyperactivity in some ways is the bigger challenge in my life, is trying to manage burnout whilst everything is so fascinating. It's really hard. And you will still see people using the term ADD. That's still bouncing around out there. Sometimes I think it's a little ableist in the way that it's used as a sort of, I'm a woman with ADD, and that's not like ADHD. There's something in that, I'm not sure, but it's not really officially been diagnosed since 1987. So some people still have that diagnosis and are entitled to use that, of course. However, nowadays we would be diagnosing ADHD. Now, I don't do assessments, and I think it's valuable to outsource that anyway and to have a second opinion. I wouldn't send anyone for an assessment unless I was really, really certain that they're not going to be wasting their money and that definitely they're autistic or definitely they're an ADHD, and we've really explored it, and then we go for an assessment. And I would encourage you to spend time exploring that with your clients. Take your time. Don't sort of ship them off to a psychiatrist or someone else to do the assessment, to spend all that money, unless they're really clear about how they show up as an ADHD, because they're going to need to competently explain that to the assessor. There are still way too many people assessing ADHD out there who are very quick to say, no, it's just trauma, or my favorite, no, it's just anxiety, when we really know that anxiety is almost the natural state of an ADHD because of the chaotic mind, the rapidly thinking, the going from one thing to another, forgetting things, missing appointments. Anxiety naturally comes out of life with difficulties with executive functioning. And so it's not ADHD, that's not anxiety that is causing these difficulties. It's the other way around. These difficulties are resulting in anxiety. And that is probably one of the biggest realizations I've had over the last year or two, is that there's a presentation of anxiety that really, it's an ADHD or ADHD autistic form of anxiety. I had a client recently, a little while back, who said to me, I'm just anxious all the time. And rather than taking that at face value, I said, can you explain to me what anxiety feels like for you? And they said, it's like a million thoughts happening all at once. And this kind of fog, and I just feel really overwhelmed. I said, honey, that's ADHD. That describes perfectly the sort of mental experience of many ADHDers, a million thoughts all at once. And so treating, if there's a person like that, like slowing down and finding out what actually anxiety is for you is really important, because in that instance, we could look at medications. ADHD medications are probably more likely to be helpful than antidepressants, for example. And all sorts of planning and strategy as a therapist with this client isn't going to get rid of that buzzing thing that's going on in their brain. So signs of inattention, there are many. Here's some of them: procrastinating, needing to do things immediately or possibly not at all, and you say, I'll do that right now, because if I leave it for even a minute, I might forget about it. Needing a deadline to complete a task and relying on calendars, lists, and alarms to create urgency and structure. Double booking yourself or arriving late. Overlooking important details. See, this is inattention in a nutshell for me. I will be in a shop looking for a certain item. Every time I finally ask a staff member where it is, I'm almost always standing right in front of it. It's because I see things, but I can't see them. I get overwhelmed and I cannot discriminate between them all. And the thing that I'm looking for, my eyes just skip over it. This classic sort of, that's my classic experience of inattention. I will be looking but not seeing all sorts of things. Yeah, signs and directions and all sorts of things like that. Not reading the instructions, finding boredom intolerable. I don't actually know what it feels like really to be bored, because I just never sit still long enough, I think, to become bored. Find that really, yeah, I'll always find something to do. really quickly tiring of new hobbies and having difficulty completing tasks once the novelty has worn off. We talked about those half-finished projects, right? Disorganized home or workplace or both. Losing the train of thought mid-sentence. Some people at this point who are watching this webinar are going, oh, that's me. Losing personal items and losing track of time. Time is a very fluid construct, isn't it? It's really arbitrary the way they define minutes and hours, really, isn't it? And so all of these are signs of inattention, signs of hyperactivity and impulsivity, always being busy. The more obvious ones are the externalized ones, right? So always being busy, feeling like you should be doing something. I used to think, okay, I've got 20 minutes before I need to leave to pick up the kids for school. What can I do in that 20 minutes? It's taken a lot of practice and discipline to say, I've got 20 minutes before I have to pick up the kids from school. I think I'll just sit here and scroll on my phone. Maybe I can do Wordle or have a cup of tea. Actually doing more or less nothing, but I'm kind of doing something, but not having to squeeze in a quick trip to the shops or quickly hanging out washing or something like that. Just allowing a little bit more space has taken a lot of practice. Our ADHDs will add something into that 20 minutes, but they have difficulty estimating that time, and then it actually takes an hour and then they're late. And this happens all the time. Difficulty sitting still, needing to fidget or move. I have many fidgets here with me right now. Ability to hyper focus and complete an enormous amount of work very fast. You hear stories of ADHDs doing their whole week's work in basically half a day. Being unable to rest or relax even when tired, definitely me. Difficulty waiting in lines, also queues or traffic, definitely me. Engaging in frequent side quests, just constantly going on tangents. I should be doing this, but actually now I'm doing that. How did that happen? Don't know. And internalized, this is where you'll often see female clients who are in your practice. They're on the outside, they look calm, and inside it's all going on. Internally very restless and agitated. And I've even had clients who speak very slowly, and it's this habit of really controlling themselves and internalizing this hyperactivity. So they're behaving in a way that is the opposite of what's going on for them, because inside they're having this rapid looping anxious style thinking or a noisy chaotic mind, and getting impatient because other people are talking too slowly. And so verbally you'll see people talking loudly, quickly, or even talking to themselves, skipping from one topic to the next. In therapy, they'll go, oh, and this happened, and this happened, and this happened, and this happened, and that's the week, and not really pausing on anything, blurting things out without thinking, which can get you into all sorts of trouble, interrupting and completing other people's sentences because they're talking too slowly, and you've already worked out everything they're going to say because your mind can join the dots very fast. Again, there's probably even more people right now who are going, oh, that's ADHD. That sounds familiar. So when to screen for ADHD, and some of you will be hopping onto NovaPsych and screening yourself straight after this, I imagine. When you've already been identified as autistic, because there's an 85+% likelihood that you would be an ADHD. Or when you're screening for autism, I would always throw in an ADHD test into that nowadays as well. When there's one or more of those co-occurring mental health problems or physical health problems, especially long-term chronic anxiety. I had one client who came to see me and had over 30 years of therapy for anxiety and was still one of the most anxious people I'd ever spoken to. And we later worked out that she was autistic and an ADHDer. Someone who isn't responding to your standard therapeutic approach, it's worth thinking what else is going on here. Any client who reports feeling chronically overwhelmed or disorganized, forgetful, or is relying on tight control via compensatory strategies. Clients who are unable or have great difficulty completing their homework and will often forget the content of your sessions. They have difficulty or are unable to establish and maintain routines. So when I'm working with a client with binge eating difficulties, that often they're binging at night, so from after work through the evening, often they've not had lunch or breakfast. They've forgotten to have lunch during the day, and so they're not aware that they've got hungry until they're starving. That's an interoceptive difference they've got too. So we work on establishing lunch, and it's very hard. It's a really hard thing to establish that routine, to stop what you're doing. Requires task initiation, switching sets, stopping the flow to have lunch is really, really hard. And ADHDs will have a lot of trouble and have tried all sorts of different routines and structures to solve this problem and haven't had any luck. People with binge eating, and they're not coming to us after just noticing it happening one or two times. They're coming because they've had problems with this for years and tried everything already, right? Difficulty attending appointments or often late, and the verbal hyperactivity, changing the topic quickly, being easily distracted, losing train of thought in session, all of these kinds of things. I've had clients who are virtually vibrating on the couch. They have so much energy. So I always have lots of fidgets, and I only work with adults, but I'll have all sorts of fidgets. I have a basket, and I come to know which ones people like. I always have them there, and they pick it up, and I've seen people with a fidget and they're spinning it really, really fast, and their hands are moving fast and their body is relaxing until they're almost lying down, and their tone of voice, the speed of speaking has slowed down while their hand is still really, really, really busy. So having these things on hand is really important and helpful for clients. I use the ASRS for screening, and luckily Novopsych has that. And I've recently been going back, and this is the new reporting format, and I've been using this for years now, and have old reports reformatted, which is great in the new format. It has the two they're called subscales, they're the two presentations: inattentiveness or hyperactive/inattentive, motor and verbal. And I did kind of like it when they were separated out, but the same. But that's okay, because you can still pick it up in the questions. Whether they're more verbally hyperactive or physically hyperactive is interesting to explore with clients. And it compares your ADHD to non-ADHD and ADHD samples, so you can see where they sit. And it's an interesting effect on the scoring. And this is my report. I just did this a while back. And I really identified the hyperactivity at the time. So looking at it now, my score would be a lot higher. And you do see sort of uh, almost all of my clients who are ADHD is a 95% or more. They tend to be right up there. There's a sort of a flattening where that when there are obvious difficulties with ADHD, you're getting very high scores. Usually, even I made the 97th percentile. Most of my clients would be 98, 99th percentile. It also picks up inconsistencies, and when I redid the formatting, we'll talk about questions at the end. I'm sorry, I can't take questions now. When I look at it now, it picked up that I was reporting quite low hyperactivity scores in one area, and that was a bit inconsistent with my overall score. So when you're working with ADHDs, we need to be thinking about thinking beyond those neuronormative strategies. Why don't you use a diary? Why don't you write a list? Trust me, your clients have heard this countless times before. Don't be the next person. And if this was going to help, it would have done so by now. I've had many clients who've gone out and they've bought themselves these amazing planners, or they've put huge planners up on the walls or color coded, and had a lot of joy in creating this system, but not the executive functioning to maintain them. So often we'll think we'll buy that next beautiful planner or that bullet journal and that'll fix it, but it never fixes it. So when we're thinking about those 4 defining characteristics or information processing differences in ADHD, we need to be thinking about scaffolding the difficulties and harnessing strengths, specifically executive functioning. Now, as a psychologist, I know now that I can waste a lot of time in therapy, and there's never enough time in therapy. I actually set a timer to make sure I finish more or less on time. Um, so there's never enough time in therapy. So if I wanted to spend all of my time trying to help that client improve their time management, improve essentially their executive functioning, I'm going to be pushing it uphill, right? One of my kids has huge difficulties with working memory. And at the time I found this out, I looked into what you can do to improve someone's working memory, and the answer is not a lot. There were programs out there that needed to do them 4 times a week, 30 minutes a time, that trained their working memory. This is not the capacity you have in therapy to do this kind of work. So we need to be choosing carefully what our targets are. And we need to be harnessing that person's strengths and helping them restructure their life so that they can really take advantage of those strengths. So I think this is possibly one of the most freeing things as a therapist. Is there are some things that I'm not going to spend my time working on. What I'm going to do is spend my time on everything that surrounds that, that makes that easier, that makes that person's life easier, that reduces the load or the need to even use that executive functioning, that executive function. So when we're talking about scaffolding and supporting executive functioning, top priority for me is to reduce their overall mental load. So remember how I talked about when you're moving house and the removalists are here and you're packing up the last boxes and the kids are running around and who's got the dog? Where's the dog gone? And all of that's going on. We don't want to be living our life in that kind of state of panic, and yet ADHDs really often are. So we want to help them really decide what is actually important. Do we need to wear a different outfit every day to work? No, actually, I've worked with people who've worn the same outfit, white shirt, black pants, every day to work. Never had a problem with their professionalism or their work. Why not? Why not simplify the number of decisions you have to make? Do our clothes need to be in neat little rolls in their drawers looking gorgeous? No, they don't. Why can't we have a basket of clean and dirty and, the wardrobe kind of a basket for the in-between clothes that have been worn but are not quite yet dirty? And then when we wash them, they go back in the clean basket. If that's going to work for the person, then why not? Why make life harder? So many ADHDs are holding themselves to these neuronormative standards that just don't work with their brain and just end up beating themselves up for not achieving them. We can cook one meal and eat it for 5 days in a row. Why not? If that's going to make your life easier. So reducing decisions and simplifying your life, really trying to scale things back and putting in strategies to automate, to outsource, to get rid of tasks that we don't need to do. Get a cleaner. rather than spend every day of the week thinking I really should clean the bathroom, but I haven't. Get a cleaner. If you can afford it, it is so worth it. And that's the key piece of work for a psychologist, for a therapist, is to help your client overcome their intense reluctance to ask for help. It's a defining characteristic of ADHD, I think, is bootstrap mentality. I should just have to dig deep. I just have to try harder. One area of executive functioning that we can work on is building emotion regulation skills. However, we're probably spending time working on emotional awareness as much as regulation. Alexithymia and how to read our emotions. We're not actually necessarily improving our executive function, but putting in some strategies to support that person. So when this happens, I can take some time out to calm down, for example. I know this is really painful for me and I'm going to look after myself. Some self-compassion. These are making some accommodations for ourselves and finding ways to allow ourselves to recover from painful emotional experiences. And we need to make sure that we support executive functioning in therapy. So to manage, I did want to expand on this one, to manage verbal hyperactivity. I have my clients pre-prepare talking points on their phone and then they give them to me at the start of the session. I set an agenda, and sometimes we'll do things like we'll agree to have 10 minutes where we just generally catch up. There's a social support element to our work together. And then we define what we're going to focus on in that session and try to stick to that. And we need to ask our client permission to stop them. I will literally do this. When I have permission to do that, can I pause you? I'm just noticing that we're moving on to the next topic really quickly, and there was something that you said before, and I just really wanted to talk about that a bit more. It seemed really important. Can we do that? Asking for permission, and clients don't want to waste the session. They know that they're tending to talk maybe in more detail or more superficially, just a lot. They welcome that interruption. It is important to have that permission though. And to keep, is it okay if I pause you for a minute? To keep asking. And we need to support working memory and planning. Many clients, now that I've started asking, tell me the minute I walk out of our session, I forget everything that we've talked about. So I will send them a copy of my notes. I will write 1 page of handwritten progress notes and 1 page also handwritten. And I use a Remarkable, so I can just email that page, but there's many other ways of doing it that is written in a format that is still useful for me, but also useful for the client, like a to-do list or a process or something like that, or there's key steps they're going to follow. I will help them set reminders to do these things while we're in session. And I try to keep my explanations short and sharp and clear, because if you watch, you can notice that clients lose attention. Even if they really want to pay attention, they will drift. And we need to harness our clients' strengths. So your ADHD clients have this strength in this ability to hyperfocus. So how can they adapt, change the task to make it nice? As I said before, novel, interesting, challenging, or an emergency. Tasks that are nice in this way are easier to complete. So can they find the fastest way of doing something? Can they set themselves a deadline? Can they find the best process to do this with? Can they make it interesting in some way? Can they find a whole new way of doing this task? Can they create novelty? Changing the task is a really huge opportunity that we can miss. We need to help them structure an environment that allows them to hyperfocus, to minimize interruptions, to minimize distractions, or to increase distractions. I've had several clients who can only focus when they're also playing a YouTube or a podcast, they've got something going on the other screen, they actually need to upregulate in order to focus. And harnessing those repetitive behaviors, particularly for emotion regulation and impulse control. So if they need to fidget, having fidgets on hand, if they need sensory tools that give intense input like spiky or sort of things that you can squeeze that give intense input, then get those. Whatever it is that gives the client the input they need to help them regulate. We would call that intentional stimming. Intentional hyperactivity doesn't kind of work. So I'll stick with intentional stimming for that one. And, here we go. Yes, just checking. Okay. So we can track our progress towards therapeutic goals using the tools on NovoPsych, and I do use these, although some of these are quite new for me. So if we're focused not on necessarily improving executive functioning, but improving executive functioning skills or the skills to scaffold around that, you can use tools like the ACOS, which also looks and will help you track emotional regulation, for example, and where they're like how they're tracking with that. You can use the executive skills questionnaire. Now, this is measuring executive skills, not executive functioning. So if you're building some of these skills, and again, I think we're often more focused on emotion regulation and behavioral regulation, but you may want to spend some time working on time management. It's just not where I find that I get the best bang for my buck. I try to simplify their lives rather than increase their time management skills, if that makes sense. I had to throw this in, not the scope of this presentation, but I often use the DERS. I really like this scale, and I use it actually in my NDIS reports for the Australians here to talk about barriers to functional capacity. One of them is emotion regulation, because it involves really getting frozen when we feel dysregulated, having difficulty pursuing your goals. A lot of my clients have trouble engaging with their supports when they're feeling emotionally, when they're having emotional dysregulation difficulties, when they're overwhelmed. So I use this one a lot. And just to finish up now, options for formal assessment. You can, any psychologist and appropriately trained other health professional, I apologize, we may have other non-psychologists here, can also diagnose ADHD. However, cannot prescribe medications. Now, clients may initially say, I don't want to use medications. I just want to know, and that is fine. I'll talk a minute about why having the option of using medications is actually quite important. If they pay a lot of money for a psychologist assessment or some other professional and then decide they want to try medications, unfortunately, psychiatrists will almost always do their whole assessment again and they'll pay twice. So keep that in mind. And from next year, general practitioners in New South Wales, WA, ACT, and South Australia will be able to do some diagnosis and assessment, starting initially with kids and then adults. And in Queensland, they have extra training to do this, and they will in these other states as well. Queensland already offers this for children, not adults. And you could use and I know that Ben's going to talk about the WIRS 25, which retrospectively identifies childhood ADHD behaviors. So this could support the diagnosis. And as a therapist, I will be doing the ASRS and something like the WIRS and helping the client get clear on their picture of ADHD before sending them for an assessment. Because as I said, there are still way too many practitioners out there that will dismiss an ADHD assessment. So you want your client to be really clear. And I'll send a copy of these reports to the person who's doing the assessment as well, knowing that they'll still do their own assessment. If it's a psychiatrist in particular, well, everyone would still do their own assessment. The more information you can provide and clinical observations, the better. It's unfortunately, I've had clients that have their GP say, referral for an ADHD assessment. Everyone's getting that. That's just a TikTok phenomenon. But when you get that response, I can tell you that for clients who get that response, they end up with basically it takes another whole year before they're willing to go around that again. It takes a lot of executive functioning to even get to the assessment, to get the referral, to book the appointment. I factor in 6 to 12 months often for this to happen. So to get that knockback is such an enormous setback in terms of time. Now, medications before I finish. For children, and I know ADHD medications are controversial, and I would also say highly stigmatized. We seem to be so much more willing to accept taking antidepressants that have an efficacy rate of less than 50% than taking ADHD medications, which are short acting and have much, much higher efficacy rates. There's so much stigma attached to these. For children, having the ability to access schooling can have lifelong benefits. For adults, it can also be life-changing, really quieten down that thinking. You get a different effect for every person. It can really, I've had people say, all of a sudden, it's just like there's one voice, one thread of thinking in my head rather than 10 all going at once. Is that how other people? Is that how other people think? I've never had that experience. So there's two types of stimulant medications, methylphenidate, also known as Ritalin and Ritalin long-acting, and dexamphetamine, also known as lisdexamphetamine or Vyvanse. There are short and long-acting versions of each of these. It is, medically speaking, the recommended first-line treatment, very high efficacy rates and generally well tolerated. Obviously, you need to get medical advice. You do not have to have an echo, like a heart test, unless you have, according to the best practice guidelines, unless you have a history of heart problems in your family or in yourself. It can support executive functioning, but the effects are very unique to the individual, and sometimes clients will take on a lot more when they're on medication, so you have to help them monitor for burnout. They do have more or less an immediate effect. You might need to increase to the dose that is working best for you, but you don't have to, unlike antidepressants, you don't have to wait 4 weeks to see if they're going to have any effect. You should know pretty much straight away, and even a long-acting one will wear off within 8 hours or so. And stimulant medications are associated with lower mortality rates, including lower rates of accidental deaths and suicides. So there is a bigger picture here in terms of ADHD medications, and I do encourage all my clients to have this conversation with their doctor to sort of work out whether this is something they want to try. There are non-stimulant options, but they're far less effective. Atomoxetine, guanfacine, and clonidine are the three that are generally the non-stimulant medications. Okay, and I'm going to finish there because I know Ben's now running out of time, and I'll hand over to you, Ben. Thanks
Thank
for
you,
that.
Jennifer.
Thanks for your
That's really
patience.
interesting, and yeah, really lots going on in the chat and the questions. I've got a bunch of questions I'll give you at the end, but I just want to spend a few moments just demoing some of the questions that NovoPsych has available. I just want to start by talking about the fact that a good psychological assessment is not just psychometrics. Of course, I love psychometrics. I live and breathe psychometrics, but I also understand the limitations of psychometrics. And no questionnaire in itself can do a diagnosis of anything. People often ask me, is this particular questionnaire diagnostic? The answer is always no, because it's not a questionnaire doing a diagnosis. It's an expert clinician who's integrating multiple pieces of information together, and questionnaires might be a big part of that. The reason I love questionnaires is that they're standardized, systematic, objective, and reliable. But we need a clinical interview as well, and we obviously need training and expertise. The clinical interview gives us context and background, observations, impressions, and also meaning, and helps us rule out other possibilities. So I want to just, I think that that's really important just to communicate that the questionnaires that I show you can be really helpful as one part of an assessment process, but they are not everything. So I want to show you, I've shared my screen, and you can see here we are on novopsych.com. I'm just going to go to the assessment library here. And this will give you access to heaps of assessments. And I'm just going to click on ADHD, which will show you a list of the ADHD specific assessments that we have. The first one I would like to show you is the Adult ADHD Self-Report Scale. This is a pretty short scale. It's just 18 questions, and it's designed to measure symptoms of ADHD in adults. And you can see that if we press here on Administer Now, here is what one of the questions is. How often do you have trouble wrapping up final details of a project once the challenging part is done? And of course, you can just click through that, and a client can just click through that as well. And then once they click through that, it will produce a report that's sent to you, their clinician. And what this report does is it measures them against people with ADHD and the general community. So I'm just going to zoom in here and show you this. So this red zone is, and the line here is the typical score that someone with ADHD would get on this questionnaire. And then here is the typical score that someone in the general community would have. This is the 25th percentile for the community and 75th. It's essentially the two middle quartiles. And then we've got a cutoff score there. So this is a really great screener just to see, are the symptoms is the presentation consistent with ADHD? And it can break it down as well. So I think that this is a really good place to start just for basic screening. The other one I really like, and this one can go a little bit deeper to give you a sense about, in particular, what are the difficulties that the person might be experiencing, is, and Jennifer mentioned this, the Executive Skills Questionnaire, which is 25 questions. And it measures things like plan management, time management, organization, emotion regulation, and behavior regulations. And these are things that someone with ADHD or autism, for that matter, or with another cognitive or developmental difference might be experiencing. And again, if we press Administer Now, you can see some of the questions that come up. Read each item and describe how often it's a problem for you. I act on impulse. I say things without thinking. I lose things. And once the client completes that, it will give a really nice report with percentiles. And here at NovoPsych, we like presenting scores in percentiles because it contextualizes the score in comparison to peers. So, we don't know what 30 out of 75 means, but we do have a good sense that a percentile of 82 means that they're experiencing difficulties more than 82% of the population. And it gives you an overview of their executive functioning as well as these subscales here. If you're really wanting to do a really thorough job to assess for ADHD, it's important to establish whether the symptoms were present in childhood, because of course ADHD is a developmental thing, and so it's not like you have adult onset ADHD, although it can be exacerbated by menopause and other things. But really the diagnostic criteria states that it has to be a developmental history. And so what this questionnaire does is it asks an adult about what they were like as a child. By doing so, it can establish whether ADHD was likely to be present as a child. And of course it does rely on the memory of the person who you are assessing, but it has been shown to be pretty reliable. And we've just recently updated this report actually, and it has been shown to reliably distinguish between those without ADHD and those with ADHD, even in clinical contexts where there are all sorts of comorbidities present. And so, for example, this sample report, you can see the client scored in the high zone, which is below the clinical cut point, but certainly much higher than a non-clinical sample would likely to be experienced. And so with this can give you some more data points in order to tick the boxes on knowing whether someone's meeting diagnostic criteria. The final scale that I really love. So I really love outcome monitoring. And I believe that if we're working with someone with ADHD and we're trying to intervene in ways and improve their life, that we should be able to measure the impact that we're having. And so the ADHD Clinical Outcomes Scale, or the ACOS, is 15 items. And it's a tool developed to monitor symptoms over time in individuals with current or potential ADHD. It assesses the main symptoms of ADHD as well as co-occurring mental health difficulties, such as anxiety and depression, and challenges in daily functioning. So this one is not about assessing someone to see whether they've got it. It's really about seeing how they're going over time. And of course, in NovoPsych, if you administer an assessment more than once, it will do a graph over time. And so you can see here that this was first administered in November. And you can see that this person's score is generally reducing, which means they're coping with life better. And you can see that some of the subscales that it measures are attention and functioning difficulties, hyperactivity, impulsivity, and emotional dysregulation, co-occurring mental health problems, because we know that's important, and risk behaviors. And so, I'm really passionate with being able to show that the interventions we're doing are effective. And so I really encourage you that if you are working a lot with people with ADHD, that you, consider giving this questionnaire to them every couple of months or so, just to see where they're, how they're going over time. So if you are interested in getting access to them, just head to novopsych.com, go to the assessment library, and then, yeah, have a look at them. You can press administer now just for a test to see what the assessment's like, or you can sign up if you don't have an account, or of course, most of you have an account already, and so log in and administer them through NovoPsych by emailing them to the client. So I'd like to now, Jennifer, I'd like to ask you some questions because, gosh, there are a lot of them. And it was really hard to keep up. So I really like the way that you were talking about scaffolding and supporting clients to reduce their mental load. I suppose that was the key thing for me. Kelly asks, she says, what do you think the actual prevalence of ADHD would be? She goes on to say that sometimes at work she isn't convinced that anyone neurotypical exists. And I suppose that begs the question, where is the line between ADHD and normal inattention?
Well, all I can do is stick with the estimates. There's quite a few studies that have said around 5%. I just would say, though, that um, us us neurodivergent people do tend to stick together. We seem to find each other. And so you will end up with a whole organization, particularly in a field that is really attracts people that that has a lot of variety or novelty, or is associated with a not very common autistic spin. And psychology is a hugely common autistic spin, actually, as is looking animals and humans can both be. So very common autistic interests. So just like you might also find if you worked in an engineering firm or an IT firm, a lot of people with similar interests and neurotypes, you will also find it in other industries. So I tend to say the same thing. Was it Kelly? I tend
Yeah.
to Yeah, I say the same thing, like, where are all the neurotypicals? And I don't even use that word because I tend to think when you look at all the different forms of neurodivergence, there are dozens. I sort of say, who gets to call themselves neurotypical anyway? And like, prove it, right? Because we have to prove it. So you prove that you're not any of these things, and then I'll believe you. So I do think there's the actual incidence of neurodivergence is over 20% of the population. I think ADHD is a big chunk of that, but there's a
So
lot of other types.
what do you think is a bigger risk, right? Do you think that it's a bigger risk to a person to have ADHD and not know they do? Or do you think it's more risky to be incorrectly diagnosed as having ADHD? Which do you think is more likely? Do you think it's more likely people just missed, skipped, fall through the gaps, or it's more likely that people are being given the label when they don't have it?
It's very rare that people get given the label of ADHD or autism when they don't have it. And
So
a
he,
study recently came out for autism that found that the people who self-identified, and ADHD is the same, do an enormous amount of self-research and self-reflection to come to that conclusion for what is essentially a stigmatizing diagnosis. You don't, it's not really cool or trendy. And so I think they found that people who self-identified at very, very low rates when they actually assessed them of people who didn't meet the criteria.
so
So
people
it's very rare that people, it's much more common that people would be refused or denied a diagnosis who are actually ADHDers.
So I've seen similar research where people are actually very good at self-identifying as ADHD or autistic. Some very good research. And so that, I suppose, the question I've got is, why do we need to pay $1,000 for a diagnosis?
Um, because people are earning a living. The ADHD diagnosis is not actually nearly as complex as getting an autism diagnosis, but the costs are right up there. I used to always send people to telehealth psychiatrists who were charging $600 or $700 for essentially 2 1-hour appointments and a standard report that was just minorly, the few details typed in. They're now charging $1,800 for the same service. It's no different.
But
And so
there's,
it's what the
yeah,
market will pay, isn't it?
there's no
In
doubt
that
that there is
instance.
an assessment industrial complex, as I put it. Um, and
Yeah.
a few people in the questions, and to address this lack of access to diagnosis and assessment, a number of states have allowed GPs to prescribe medication. I suppose it's also important to make a distinction between who can um, you know, psychologists can assess. Absolutely, we always have been able to be. But now that GPs are getting the right to prescribe for ADHD, they will inevitably take on more of an ADHD assessment role. How do you think that's going to pan out?
Yeah, I think overall it's a great thing. I think the risk of people being false positives is very low, and the potential loss, particularly in children, of years of education, the impact of that is enormous. So, trialing children on what are essentially short-acting medications is a really great idea. If they don't help, then okay, don't use them. I do wonder whether GPs might be a little bit more willing to consider a psychologist's assessment in support of a diagnosis than a psychiatrist is.
Yeah.
Psychiatrists have they will I don't know any of them who will actually just take a psychologist's thorough assessment and go, okay, fine, I'll prescribe you. They will, and that it's because it's been drilled into them that, this is a Schedule 8 medication and you need to have done, there are laws, they need to have done their own assessment.
Yeah. Yeah.
The GPs will be, I looked into this in preparation for today, there'll be tier one and tier two. So tier one is a lower level of extra training that GPs will have to do where they can continue medications that are already been safely prescribed. And that will save people thousands from having to go back to a psychiatrist just to essentially get a new script for Ritalin every year or go up or down 10 milligrams. That GP can manage all of that. And I think that will take a lot out of that potentially will take a lot out of the sort of overload that psychiatrists have.
Yeah.
A lot of people out of that pipeline, and I think it's pretty safe. So it's certainly the GP will have additional training for tier 2 assessments, which will be assessing and initiating medication. And so they're starting to roll out that training now, is my understanding. And I guess they'll be given assessments and checklists, and anything more complicated, they should be referring on to someone else. I saw a question in here about differential diagnosis. Anything that is more complicated or has certain risk factors, they should be referring on to a psychiatrist. I would think that that pathway will still exist.
Yeah, and I think certainly differential diagnosis on ADHD can be tough at times. I've got a question for you. So, when I'm seeing a therapy client and I've known them for a long time, and then I identify that there's ADHD. Um, I have been in the practice, if it's a straightforward case of making the diagnosis, or saying to them, consider this an official diagnosis. I know that gold standard best practice is to pay someone a few $1,000s to do it. Um, uh, would you say that my practice has been bad, or do you think I might be able to continue doing that?
Um, I don't think it's bad if you feel like you've done a thorough clinical interview, that you're very certain and you've done assessments to support that, you've collected the history according to the criteria, yada yada, then no, that's absolutely appropriate. You're within your
I'm
skill
so
set to
I'm
do
so
that.
pleased, Jennifer, you didn't just
There you
rebuke
go.
me in front of a
I
thousand
sign you
people.
off. I don't do that. Like I do a lot of that analysis, but I do prefer getting a second opinion. But I'm comfortable in the sense that I will say to people, I'm pretty sure you're an ADHD. Let's work on that basis and
Yeah.
let's think about, do you want to try medications? Like I won't say consider this an official diagnosis, not because
Mm.
I'm holding out, but I will talk about it just as confidently. Like, this is all of the signs of ADHD, and this is how it's impacting your life, and this is what we could do about it. And then, really, the decision is, do you want to try medications or not? Because
Yeah.
a diagnosis of ADHD is helpful clinically, but the
Yeah.
medications are the key, really, if you
Can
want to
be
try them.
really can be really helpful, can't it? The revelation when people realize. And
Oh,
hey, Jennifer, thank you
mm,
so much for tonight. It's been really eye-opening, and your depth of experience has been really fantastic. So thank you for sharing with us. If people are
thank you.
interested with further training with you, we've only had a taster tonight. Where can they find you?
They can find me on my website. That's the quickest way. So it's just jenniferkemp.com.au. I've got a bunch of training coming up. Yeah. And I've even got a 15% discount off the professional tickets for the next few weeks. So I've got something coming up with rejection sensitivity, which is very common in ADHD, RSD. I've got a program at the end of the year, which is how to really provide long-term, short and long-term therapy for autistic and ADHDers. So how to think of short-term goals, long-term goals, and put it all together.
Great.
And I've got one with Praxis as well, Praxis CET, which is focused only on autism, and that's starting in September as
So
well. And
the
all those details are on my website for that one
and so they're
too.
all on the website. That's
Yeah. Well, these ones will
Jennifer
be up
Kemp.
by tomorrow. The rejection sensitivity one's going up tomorrow.
All right. And there is a QR code here, and I think there's a
Mhm.
discount code, which is great as well.
Yeah.
So for all the attendees, thank you for coming out tonight. The dedication to you putting time aside so that you can improve your skills to better support your clients is commendable. We're all in this because we want to improve as many lives as we can. We do have another webinar coming up on recovering from trauma with Dr. Sherelle Smith. Do check that out. Go to novopsych.com and have a look at that. Of course, all of the webinars that we do are free. So if you've enjoyed tonight and got something out of it, we think that the next one might suit you as well. And if you haven't yet got a NovoPsych account, do go to novopsych.com and sign up for a free trial and check out some of the assessments that we've got. We also do have a NovoNote AI scribe, and we do have this beautiful template for the Diva 5, which is a diagnostic interview for ADHD that can, go a long way to write ADHD reports for clinicians. So that is something to look out for if you haven't seen it yet. So thank you so much, everyone, and I'll see you in the next one. Bye.
Bye.